Hello friends and welcome back. Today I'm going to talk with you all about cardiovascular disease. So it's no doubt a big topic to discuss as there's a ton of complications, comorbidities, and then medications to discuss. I'll try and present things in a very clear way, making it hopefully easy to follow and comprehend. Like I said, there is a lot to cover, so of course I'll try and focus on the topics that I know you'll need to know when going to take your nurse practitioner board's exam. I'll discuss things with you like hypertension, hyperlipidemia, heart failure, peripheral artery disease, murmurs, and then some specific points that you sort of just have to know when going to take your exam. As always, don't forget to subscribe to this channel if you found this video helpful at all in studying for your boards so that you can be alerted when I post more study videos. And now on to cardio. There are many risk factors that increase the likelihood of cardiovascular disease, multiple of which are modifiable. This is huge from a primary care provider's standpoint because this is something that we can try and modify to prevent our patients from having a cardiac event. This is an area where we really get to make a difference in our patients' quality and quantity of life. So what are these modifiable factors? I listed 4 here that we all need to know, and they include hypertension, dyslipidemia, smoking, and then diabetes. For today, we will discuss in depth hypertension and dyslipidemia. All of our patients, regardless of their cardiac status, should be educated about making healthy lifestyle choices, eating healthy, stress management, exercise. All of these things can help reduce risk for cardiac disease. We should also be screening our patients for metabolic syndrome, which is highly associated with cardiac disease, diabetes, and mortality. So increased waist circumference, increased triglycerides, blood pressure, fasting glucose, and decreased HDLs. 3 out of the 5 need to be present in our patient for us to be considering metabolic syndrome. So hypertension is considered to be the most modifiable risk factor for cardiovascular disease, even more than smoking and diabetes. So what is considered hypertension? There are a couple of guidelines out there, and then after reviewing the testing websites, technically it seems that either one is fair game, but I have heard that AANP and ANCC tend to favor the AHA guidelines. Regardless, I can tell you that the questions never seemed to be phrased in a way that it was unclear whether or not the patient had hypertension. Instead, the questions were more focused on things like choice of drug class, contraindications, side effects, and then follow-up for these patients. So on the left here is the table by the ACC and the AHA. And normal blood pressure is a systolic less than 120 and diastolic less than 80. They stage hypertension. Stage 1 is 130 to 139 systolic or 80 to 89 diastolic. And then stage 2 is greater or equal to 140 systolic or greater or equal to 90 diastolic. And that is stage 2 hypertension according to their guidelines. And then on the right hand side is the JNC8, and they factor in age. So they say in the general population, pharmacologic treatment should be initiated when blood pressure is 150/90 or higher in adults 60 and older, or 140/90 or higher in adults younger than 60 years. There is some slight differences there in what they qualify hypertension, but you'll see that the treatment remains the same. So first-line treatment for hypertension includes these 4 drug classes: thiazide diuretics, your ACE inhibitors, your angiotensin II receptor blockers, and then your calcium channel blockers. Those 4 drug classes are first-line treatment. Thiazide diuretics includes your hydrochlorothiazide and then also thiazide-like diuretics. For example, chlorothalidone, which is very favored after research has shown it to reduce cardiac events. Okay, so just a couple of key points before we dive into meds. So number 1, you'll want to reevaluate your patient in between 4 to 6 weeks after starting them on a blood pressure medication. By this time, the full effect of the med should have taken place. If the goal isn't reached, then either you're going to step up therapy or add on an additional agent. Generally, rule of thumb is that a blood pressure medication dose should be stepped up 1 time, and then if it's still ineffective, an additional agent then should be added in. If the blood pressure is less than 20/10 above goal, then you might be able to manage it with monotherapy or 1 drug, whereas if it's over If it's greater than that, then or unresponsive to monotherapy, then dual therapy might be indicated. So the first drug class we have here are thiazides and thiazide-like diuretics. I shared some normal dosages here for your reference, but more important than the numbers, it's important to understand if these normal dosages were provided to you, that you would know to step up the therapy from 12.5 to the 25 if the patient's blood pressure wasn't reaching goal on that lower dose. So more important than remembering numbers for dosages, it's understanding the concept of just stepping up therapy when the blood pressure goal isn't being met with that lower dose. So there are some possible side effects involving the electrolytes when taking thiazide diuretics, including both hypokalemia and hyponatremia. So the risk of hypokalemia can be decreased by adding either an ACE or an ARB. But also things like hyperglycemia, hyperlipidemia, and then hyperuricemia can also be seen. This makes sense as to why this drug class would be contraindicated in our patients with gout. It is also contraindicated in patients with renal failure, sulfa allergies, and then concurrent use of the drug lithium. Some details that are good to know about thiazide and thiazide-like diuretics. One is that this drug class is beneficial to osteoporosis. It decreases calcium excretion and it stimulates osteoblast production. So this might be useful if we have a patient that has osteoporosis. Also, there is a risk when combining hydrochlorothiazide with calcium channel blockers in the elderly population. This can actually cause acquired neutropenia. This is due to hydrochlorothiazide suppression of the bone marrow combined with the calcium channel blockers suppression of the neutrophils. And this last bullet point here, which is something I already kind of touched on, but it's that chlorothalidone is the recommended first diuretic choice. And it's due to not only its effectiveness in reducing blood pressure, but also that it reduces the risk of cardiovascular events. So next up are ACE inhibitors, and this is another first-line drug for hypertension. These are the drugs that end in pril, P-R-I-L, pril. So side effects to look out for these include a dry hacking cough, hyperkalemia, hypotension, and then an acute kidney injury. Here's a contraindication that you really are going to want to know, and that is that ACE inhibitors and ARBs cannot be combined, as it greatly increases the likelihood of adverse drug events. So you will never combine the ACE and ARBs, and if you see that on a question, you know that that is contraindicated. Lastly, an important key point is that ACE inhibitors have shown to be cardioprotective and that they are the first choice for a blood pressure medication for those patients with heart failure, cardiac disease, diabetes, and chronic kidney disease. So here we have angiotensin II receptor blockers. These drugs have a very similar profile to the ACEs. They have side effects like hyperkalemia, hypotension, and then possible kidney injury. ARBs, however, they're less likely to cause that annoying dry cough that we see with the ACE inhibitors, and it's a good choice to switch to if our patients are experiencing a cough with that drug. Again, this is of course contraindicated with the use of ACEs, and I don't remember if I mentioned it in the previous slide, but both ACE inhibitors and ARBs are contraindicated in pregnancy. If our patients are on either of these drugs while pregnant, we want to switch them immediately to a blood pressure drug that's found to be safer in pregnancy. Generally, labetalol will be your choice. Finally, we have the calcium channel blockers. This last group of the 4 first-line drug classes for hypertension is divided into 2 subgroups. First being the dihydropyridines, and that includes drugs like nifedipine and amlodipine, so ending in pene. And then the other group of calcium channel blockers are the non-dihydropyridines, and that includes both verapamil and diltiazem. So the calcium channel blockers that end in prene have side effects like headache, lightheadedness, flushing, and then dependent peripheral edema. Verapamil and diltiazem, they include side effects like constipation and bradycardia. This drug class is contraindicated in our patients with heart failure with a reduced ejection fraction, a second or third degree heart block, and then concurrent use of a beta blocker. Also, again, this is contraindicated in pregnancy as well. This drug class is also used for rate control, and so it'll be a good drug choice for our patients with AFib or angina. This slide here discusses both alpha blockers and beta blockers. So these drugs are not first-line antihypertensives, but they do have specific indications when they are useful. For example, the alpha blocker terazosin, this is indicated in the treatment of BPH and can help to reduce blood pressure as well. So it's a good possible option for this population. Also, beta blockers, they have shown to be beneficial in our patients post myocardial infarction. So this is something to consider as well. But remember, beta blockers are contraindicated in patients with COPD and asthma as they can cause bronchospasm. So hypertension carries with it the risk of ocular disease, most frequently being diabetic retinopathy. For this reason, a fundoscopic exam is warranted in all patients with a new diagnosis of hypertension. Microvascular changes, they can be seen and are classified as mild to severe. It's not important that you know which indicates a more severe disease, but instead that you are aware things like AV nicking, flame hemorrhages, and cotton wool spots indicate ocular disease related to hypertension. All right, so we made it out of hypertension, and now we are on to our next modifiable risk factor for cardiovascular disease, dyslipidemia. So here is a lipid panel of your normal values, and I always remember L for lousy when thinking of the LDLs. Important to note that if we are drawing a lipid panel on our patient, that they do not eat a fatty meal within 8 hours of the blood draw, as this will definitely skew the results. So we found out that our patients have dyslipidemia. What do we do about it? We initiate statin therapy. So before we discuss the guidelines for statin therapy, it's important to know and appreciate the usefulness in an atherosclerotic cardiovascular disease risk calculator. And this factors things like cholesterol, blood pressure, history of diabetes, and then calculates a person's risk of having a cardiac event within the next 10 years. So between 5% and 7% risk of an event within the next 10 years, this is considered a borderline risk. And then anything above 7.5 is going to be higher than we want our patients to be at. So the risk calculator, it's available to everyone. I provided a link there. You can use it and check it out. But the AHA, or American Heart Association, provided us with really great guidelines of when we're going to start our patients on statins. And I included them here for you. But number one, if our patient has active cardiovascular disease. So they've had a history of stroke, they have peripheral artery disease, aortic aneurysm. Those types of things are going to warrant a statin. LDL is greater than 190, that's huge. So yeah, regardless of risk factors, they're going to go on a statin. Between 40 and 75 with LDLs greater than 70 and have diabetes, those patients should be put on a statin. And LDL greater than 70 is not that high. The issue there is that they have diabetes. And then between 40 and 75 without diabetes, LDLs greater than 70, but a risk of 7.5 or higher. So remember, that is a number we don't want to have. Those patients also need to be put on to a statin. So statins vary in their intensity, and depending on different factors, this will help guide us in our choice of medication. I listed the statins for you at the top. They all end in statin, so that makes it pretty easy. And then I just remember that atorvastatin and rosuvastatin have a high intensity option, and that the remaining are more moderate. Generally, we begin with a more moderate dose of a statin. If our patients have a risk of greater than 20% of a cardiac event within the next 10 years, then a high intensity statin should be initiated because that risk is huge. Prior to starting our patients on a statin, we will want to check their liver enzymes, thyroid function, and then their creatinine kinase. The importance of checking thyroid function is because hypothyroidism is a potential cause for dyslipidemia, and it also makes the patient more susceptible to experiencing something like muscle toxicity. And we're going to discuss this a little bit more on the next slide. An important side effect to be on the lookout for when our patients are on statins is muscle toxicity. Symptoms of this include myopathies or muscle pain and weakness, and they usually appear within weeks to months of beginning a statin. If our patient reports these symptoms, we want to stop the statin and not only wait for the symptoms to resolve, but also for the creatinine kinase or the CK to return to baseline. And this is why it's important for us to get a baseline CK before initiating the statin. After the symptoms and the CK have resolved, then we'll reevaluate and determine whether to continue, switch, or stop the statin. Rarely, rhabdomyolysis can occur, which is associated with a CK level of greater than 10 times the upper limit. And the patient will have symptoms again of myalgia, weakness, and also something called myoglobinuria or dark colored urine. And these patients, they need to be monitored closely inpatient, and they will also not be restarted on a statin. To help combat these statin-associated muscle toxicities, we can check for possible drug interactions before initiating the statin. Examples of drug interactions that could increase the risk of myopathies include calcium channel blockers, niacin, grapefruit juice, and fibrates. So, something to look out for before beginning our statin medications. Follow-up for these patients should include an LDL check about 6 to 8 weeks after beginning a statin or changing a statin therapy. And then once the LDLs are found to be in that desired range, it's reasonable to check them every 12 months. What about triglycerides? When do we treat for those? Believe it or not, we're not going to treat for triglycerides until the patient has severe hypertriglyceridemia, and that's a fasting triglyceride level of greater than 500. Once it's this high, then we will go ahead and initiate a fibrate in order to not only reduce the risk of a cardiovascular event, but also to reduce the risk of acute pancreatitis, as high triglycerides are actually a leading cause of pancreatitis. All right, so moving on from dyslipidemia, I'm now going to discuss heart failure. So, what are some symptoms of heart failure? I'm sure we've all treated these patients before. They report symptoms like dyspnea and fatigue. They might be tachycardic, have JVD or peripheral edema, and then oftentimes S3 or S4 can be auscultated, all of which is a direct result of the heart's inability to pump and fill with blood adequately. So CHF is divided into classes based on the patient's symptoms and limitations. I provided those here for you if you would like to review them. Of course, these patients are going to be referred to cardio or perhaps the ER depending on the severity of their symptoms, but there are some important points for primary care providers when managing these patients. Discussing things with them like lifestyle modifications, including sodium restriction, daily weights to monitor for fluid retention, and then also discussing discontinuing medications that might be contributing or worsening their heart failure. And a big one here is discontinuing NSAIDs. And in the next slide, I will definitely discuss this more in depth because this is an important point. Also included on this slide is the initial therapy for patients with heart failure, and this includes a combination of a diuretic, an ACE inhibitor, or an ARB, and then a beta blocker. An example of a diuretic commonly used is the loop diuretic furosemide, also known as Lasix. So this slide here elaborates on the concerns with the use of NSAIDs in our patients. NSAID use is associated with an increased risk of cardiovascular disease in patients with and without established cardiac disease. So to combat this, we want to use the lowest dose possible for the least amount of time. And then in patients with active cardiac disease, we want to avoid this drug class altogether if possible. So instead, patients with established cardiac disease, we want to try and use acetaminophen if possible. There are multiple other concerns with NSAID use, and I included those here. And these are important for boards and for practice. So obviously NSAID use is going to increase the risk of bleeding, specifically in those patients that are on another anticoagulant. And let's face it, if they have established cardiac disease, they're more than likely on another blood thinner. NSAIDs also inhibit the vasodilation effects of prostaglandins, and this actually increases the risk of ischemia to our kidneys. And then NSAIDs have also been known to precipitate an asthma exacerbation and elevate liver enzymes. So there's really a lot to consider here when our patients are taking or using NSAIDs. This slide here discusses peripheral artery disease, or PAD, as it's a complication that we might see in our patients with cardiac disease. I listed risk factors for you here, and they include age, smoking, hypertension, male gender, African American population, a history of atherosclerotic disease, hyperlipidemia, and diabetes. Up to 35% of patients with peripheral artery disease will report something called claudication, which is either unilateral or bilateral leg pain that occurs with activity and resolves with rest. A diagnosis of claudication is made with a ABI, or ankle brachial systolic pressure, of less than 0.9. And if you don't remember what the ABI is, no shame, because I didn't either until I started studying for my boards exam. But it is simply a comparison of the systolic pressure at the brachial artery compared to the systolic pressure at the ankle. All right, so on to murmurs. I'll be honest, murmurs had me pretty intimidated going into my boards exam, but I think if you have all of the material down that I'm about to discuss, you should be just fine on your boards. So really understanding the anatomical locations of the heart is going to make understanding murmurs so much easier. So this picture here shows you all the areas and where they are located on the chest. Murmurs are just sounds that are caused by turbulent blood flow, and they're heard loudest at the point of origin. So if a patient has an aortic murmur, it is likely that it will be heard loudest over the aortic area. I provided the descriptive locations here for you so you can review them. When you understand the location, though, I feel like it just really becomes intuitive when reading the question. But it's important to understand these locations, so go ahead and read those over. It's also important to note that two of these murmurs radiate as well. Aortic stenosis radiates to the neck, or the carotid, and mitral regurgitation radiates to the axillary. And this makes sense when looking at their locations because they are closest to those areas. Murmurs are also graded by their intensity, 1 through 6. 1 is going to be a barely audible murmur, and 4 is when a thrill becomes present. And I remember it by thinking 4, the thrill of it helped me. Grade 4 through 6 murmurs, those are always going to be considered pathologic. So this slide has a lot of information on it, but the big thing that you need to know and what's going to make answering murmur questions so much easier for you is knowing which murmurs are systolic and which are diastolic. So systolic murmurs, they start with or after S1, but they end before S2, and they are generally benign. And I remember this by thinking systolic for simple. Up-to-date reports that up to 60% of patients have a systolic murmur, of which 90% of those patients have a normal echo. So what murmurs are systolic and which are diastolic? I listed those for you here, but there are main ones that you need to know. For systolic murmurs, you need to know that mitral regurgitation, aortic stenosis, and mitral valve prolapse are all systolic murmurs. And you can remember this by the phrase, Misters always seem to be MVPs. And the B represents benign murmurs as well. And then diastolic murmurs, those start with or after S2, but they end before S1, and these murmurs are generally pathologic. And I remember this by thinking di for diastolic. I listed the diastolic murmurs for you here, and the ones that you need to know are aortic regurgitation and mitral stenosis are diastolic murmurs. And the way I remember this was with the phrase, a really misfortunate situation. And then lastly on this slide, I included some causes for continuous murmurs, including patent ductus arteriosus and coarctation of the aorta. And then finally, some other key points that we didn't get to discuss, but I know are important when monitoring our cardiac patients and for going into our boards exams. So we want to know to look for symptoms of digoxin toxicity if our patients are on digoxin. And this is because the therapeutic level for digoxin is super narrow. It's 0.8 to 2. So symptoms of digoxin toxicity include arrhythmias, GI symptoms, confusion, visual changes, specifically when objects appear yellow. With these patients, we'll want to get serum DIG levels, serum K levels, a creatinine and BUN, and then serial EKGs. And the treatment for this is actually digoxin-specific antibodies. Another important key point is monitoring the INR of our patients on warfarin. For those patients that have prosthetic heart valves, we want their INR between 2.5 to 3.5, whereas if they are on warfarin due to their AFib or a history of stroke, then their INR should be between 2 and 3. And then lastly here, I included just signs and symptoms of infective endocarditis. And that's an infection of one or more of the heart valves. And there are different symptoms that we can look for, including splinter hemorrhages, those will appear in the nails, laneway lesions, which are non-painful reddened macules found on the palms and the soles, Osler nodes, which are tender nodules on the finger pads and toe pads. And then most common symptoms include fevers, chills, fatigue, headache, murmurs are heard in actually approximately 85% of these patients. But those things like splinter hemorrhages, laneway lesions, and Osler nodes, those tend to be key phrases that pop up in questions. So those are just good to know as well. All right, so we made it to the end of the discussion for today, and as always, I have a dump sheet here for you to help reinforce those clinical pearls and key points for both practice and the board's exam. I know that was a lot of information, but hopefully you found this video helpful for you in your studies. As always, don't forget to leave me any questions or comments that you might have in the comment section below, and then subscribe to this channel if it's been useful for you. Also, don't forget to check out my Facebook group, The New NP, and join me there for more resources, and I include PDFs of all of my dump sheets there, easier for your printing. All right, guys, I will talk with you soon. Have a great one. Bye.